discussing on pulmonary embolism management. Dr. Amy Taylor will take us through this topic. She's assistant professor at the University of Virginia, is also an active member of SIR, where she serves as the key participant and chair of one of the SIR committees. Welcome, Dr. Amy Taylor.
Thank you very much. Happy to be here, and I recognize a lot of the names on this call, and I assume people are in the reading room with Hamidi as well. So it's good to virtually see you all again. All right, I'm gonna go ahead and jump in if that's all right. I'll have to share the proper screen. Okay, so I believe you should be seeing my title slide. Is that correct?
Yes.
Okay, perfect. So like Hamidi said, I am Amy Taylor. I'm here at the University of Virginia, and I'm going to talk to you about PE today. Figure out how to advance my slides. There we go. So we're going to cover sort of just some general knowledge about, PE, the different categories, what kind of scoring systems they have. We'll talk about the management. We'll briefly cover some of the major trials that have happened. And there are references to all of those trials, so you guys can look them up later if you're really interested. And then we're going to kind of walk through procedural steps of how you would actually do some of these interventions. I got a couple of case examples. I'm going to talk to you a little bit about our PE response team algorithm that we use here at UVA. And then as requested, we have a couple of multiple choice questions at the end. So PE here in the United States, at least, is the third leading cause of in-hospital mortality. We have about 600,000 PEs per year with 100 to 180,000 deaths per year. And so PE is unique in that it interferes with both your circulation and your gas exchange. And this is why it can be so detrimental to patients and really interfere with their cardiopulmonary reserve. But it's really the right ventricular failure that causes death in severe PE. And so this graphic is one that kind of shows the spiral that patients can take sort of as the different changes are happening, physiologic changes are happening in their heart due to the clot and the increased right ventricular pressure. And so you can sort of see in the area that I've circled here, where you start to get to sort of vital sign changes, where your blood pressure starts to drop and your oxygen drops. Those signs really mean that you're sort of on the backside of this curve and sort of close to really spiraling down. And so when we start to see those, that's when we start to think we need to do some sort of intervention, and quickly, in order to prevent the patient from continuing to spiral. So these are the American Heart Association categories that they place for PE. And I'm actually going to start at the bottom. Low risk PE is where you have PE that you can see on imaging, but there's really no vital sign changes and no biomarker changes. So when I say biomarker, I mean like serum troponins or proBNP or whatever it is that you guys similar might be testing. So that's low risk. Submassive is where you have the PE, and then you can have some of those biomarker changes or EKG changes, but you don't have hypotension, so you don't have the hemodynamic compromise. And then massive PE is where you have the hemodynamic compromise. Patients can actually code or just have really profound bradycardia. All of these things are very bad signs, as mentioned on that graph that I just showed you there, sort of at the bottom part of that graph. And then mortality risk sort of follows those different categories. So low risk has very low mortality. That's why it's considered low risk. Submassive has slightly higher mortality than low risk, although it's still not a super high, 3% mortality. However, about 5% of those will actually decompensate clinically into sort of the massive category. And then massive category really jumps up. So then you have 25% mortality. And if the patient has already coded once, then their mortality jumps even higher to 65%. So submassive and massive is where you want to try to think about your interventions. Different scoring systems that we use are the PESI score, which is the Pulmonary Embolus Severity Index, and then the European Society of Cardiology score. I'd say the ESC score is probably more useful clinically, but it does incorporate the PESI score. And then this image that I have here is just to show you sort of how you measure the RV to LV ratio, which people talk about a lot. And we use that a lot in our sort of algorithm of how we look at PE. But you're really looking at the diameter of the right ventricle compared to the diameter of the left ventricle. Normally, in a normal patient, your left ventricular diameter should be bigger than your right, right? You have more contractility and blood kind of going through your left ventricle than your right. Higher pressure. But when you have PE and your pressure backs up, then your RV gets dilated. And so you can see an elevation in this ratio. So anything over about 1.1 is considered elevated. Normal is sort of 1 and below. You need to make sure that you sort of get a nice 4-chamber view of your of the heart on your image in order to make sure you're accurately measuring this. So you may have to sort of use, if you have sort of an NPR ability with your packs, then you'll need to use that to sort of angle it so that you get this nice 4-chamber view. All right, so the Pulmonary Embolus Severity Index, or the PESI score, the original version is sort of this middle column on this graph, and you can see that you get points for all kinds of things, patient age, whether they're males, whether they have a history of cancer, sort of other kind of historical things, as well as vital sign type things. And all of those add up, and then you get put into one of 5 sort of risk categories, with class 1 being sort of low risk, and then class 5 being very higher risk. And so this sort of became cumbersome to try to calculate all of these different things. And so they came up with a simplified version, or the S-PESI, which is the right-hand column. And you can see there, it's just only a couple of things that they've pulled out from the original PESI that gives you points. And then it just is either you have no points and you have low risk, or you have 1 or more points and then you're in a higher risk category. And so it just kind of simplifies things. But the ESC guidelines, I think, are a little more intuitive and easy to follow. It does use the PESI score, and so you can see that is the second column of what they're, if they have either class, if you're using the original PESI score and they're either class 3 or above, or if they have a simplified PESI score of 1 or more, then that's considered the positive in that column. And if not, it's negative. So it breaks down into high risk, intermediate risk, and low risk. Notice that aligns very nicely with the AHA categories of low risk, submassive, and massive PEs. And so it mirrors that, which is, I think, why it's so easy to use. And then the intermediate category is broken down even further into intermediate high risk and intermediate low risk, based on sort of biomarkers or signs of RV dysfunction. So signs of RV dysfunction, again, we're looking at the RV to LV ratio, and then as well as the serum biomarkers of troponins or BNP. And so usually when we here at UVA, at least, are sort of on the phone and talking to teams about PEs and whether or not we need to intervene, it's usually these intermediate patients that we're talking about. Low risk patients generally get anticoagulation alone, and they don't need further intervention. High risk patients or massive PEs, those are the ones that need, emergent intervention. They're usually going to need ECMO or something else before we even intervene on them. And so they sort of already figured out what pathway they're going to need to go down. It's these intermediate ones where we're sort of talking like, oh, should we trial anticoagulation, see how they do? Should we, do lysis? Should we, what is it we should do? And so there's a lot of more discussion that goes on with those intermediate patients. So management of PE, again, systemic anticoagulation is the mainstay. That's standard of care, which for us is either IV heparin, or we also use Lovenox a lot, the sub-Q injections. And then transitioning that into some sort of an oral anticoagulation, whether it's warfarin or Eliquis or something else. You can also give systemic thrombolysis, so giving TPA. Again, here in the States, we typically use Alteplase. Directly through an IV. So, a big bolus through the IV, so that it goes systemically and works. Again, a lot of massive PE patients may end up getting systemic thrombolysis, sort of out of the gate because they're doing so poorly. And then catheter-directed thrombolysis, which we're going to talk about a little more detail later, which putting a catheter directly into the pulmonary artery and then delivering the TPA directly to the clot. This can be done sort of with or without ultrasound assistance. When I say ultrasound assistance, I mean those special catheters, which are ECOS catheters. I think it's the only brand that has them, where they use ultrasound waves to sort of help, in theory, break up the clot a little bit to allow the TPA to penetrate a little bit deeper. Is the theory of why that helps. Mechanical thrombectomy, so using aspiration thrombectomy, either with penumbra or Inari, versus just catheter fragmentation with a pigtail and just trying to break it up into smaller pieces. Surgical embolectomy, so actually opening up the patient's chest and then pulling out the clot directly. Regardless, the goal of any of our catheter-directed therapies that we're doing is rapid debulking of this central occlusive clot. We're generally not going to rapidly get rid of the sort of distal clot that's in the more peripheral part of the lungs, but we're trying to get rid of that central clot that's causing the buildup of pressure in the right heart, in order to relieve that right heart strain and improve their perfusion. So contraindications to thrombolysis, we kind of break them down into two categories: absolute contraindications and relative contraindications. Basically, all of this boils down to anything that increases your risk of bleeding, because obviously if you're giving them a thrombolytic, then they're going to have a higher risk of bleeding because you're breaking down any sort of thrombus. And so you need to make sure that's going to be safe. So the thing we worry about the most is sort of any intracranial hemorrhage. So if they have a history of intracranial hemorrhage, or if they have anything currently going on in their brain, so if they have an AVM, if they have sort of a neoplasm in their brain, if they've had a recent stroke, these are all things that really increase their risk of intracranial hemorrhage, and we would not want to do any thrombolysis on them. And then other things that might lead to major bleeding, if they've had major abdominal surgery or any sort of spinal surgery, or anything like that, any recent trauma that you're worried about causing a major bleed, you would not want to do this. And then we have some relative contraindications, including age. So anybody that sort of older patients are at higher risk of bleeding in general. If they have been using anticoagulation, pregnant patients, we really worry about using thrombolytics on. We have used thrombolytics on pregnant patients, so it's, again, not an absolute contraindication, but you really want to have a conversation because you can cause placental abnormalities and placental abruption with thrombolytics. So those are the things that we think about. And then just sort of a side note on intubation, because a lot of these patients, obviously, PE can interfere with your oxygenation, and so patients may get to a point where they can no longer control their bad respiratory failure, and they also need intubation. But we try to avoid using any sort of an induction agent during intubation, because that induction agent can cause severe hypotension. These patients are dependent on all of the preload in order to keep their heart pumping, because again, the right heart pressure has backed up, and so you have to have a lot of preload in order for the right heart to pump it all. So if you have hypotension and you suddenly lose all your preload, your right heart is going to completely fail, and so then you're going to end up in a worse spot than you were. And the patient's going to code. So we've seen it happen here at UVA. If patients are not doing well, and then they try to intubate them, and then they completely go into cardiac arrest. And so if the patient has to be intubated, we tell our anesthesiologists to try to avoid using sort of any induction agent, but generally we just try to avoid intubation at all possible. So we only use it in absolute emergencies. Okay, so there's a lot of trials that have happened. I'm not going to go into detail on all of them, or really any of them. They are listed here. Again, all of the references are listed. If you guys want, you can have a copy of these slides so you can have them. But we're just going to kind of briefly talk about them. So the perfect first one was perfect, and that was a multi-center registry of sort of any sort of catheter-directed therapy. So it could have been mechanical, it could have been thrombolytics, it could have been anything that was catheter-based. And basically it just showed that these things can be used and have good success rates, and they're safe. And that was kind of all it showed, or all it was meant to do. And then Ultima was a trial, randomized controlled trial, one of the first randomized controlled trials put on by ECOS, that was looking at their ultrasound-assisted thrombolysis catheter with anticoagulation versus using just anticoagulation alone. And they, at 24 hours, they saw that there was a decrease in that RV to LV ratio in the group that had the catheter-directed intervention, but not in the anticoagulation alone group, which makes sense. Anticoagulation alone obviously takes a little longer to work. But they showed what they wanted to show is that they can, that using a catheter-directed intervention can decrease that ratio faster. And then Seattle 2 was sort of an expansion on that, again with ECOS, but this one was just a single arm cohort study. And they were, again, we're looking at their ultrasound-assisted thrombolysis, and this was basically looking at safety. And so they had, they didn't show any intracranial hemorrhage. They did have about 10% of patients with major bleeds, which matches the around 11% risk of major bleed with systemic thrombolysis. So sort of similar there. And again, they showed a significant reduction in that RV to LV ratio. And then we get into sort of the aspiration trial. So Extract PE was put on by Penumbra. Again, looking at aspiration thrombectomy and looking at bleeding rates as well as reduction in RV to LV ratio. So they showed less bleeding rates, so only about 2% bleeding rates, and then a significant reduction in RV to LV ratio. Again, sort of makes sense. You're not using thrombolysis. You don't have anything that you're dripping over a period of time. This is purely aspiration, so it sort of makes sense that the bleeding rate was lower. Flare was put on by Inari, but similar, just using a different device. And they had even lower rates of major bleed, although probably not significantly lower, but about 1% major bleed. And again, significant reduction in RV-LV ratio. And then they also looked at whether or not patients required an ICU admission, and 41% of their patients did not even need to go to the ICU. So they went from the ER to the interventional suites. They got their clot removed, and then they were able to be admitted to a floor bed, not to an ICU bed. So that saves sort of resources, and was a big part of how they justified the cost of their device, which was and maybe still is one of the most expensive devices for PE on the market. Obviously, well, at least in the United States, all of our thrombolysis patients go to an ICU for close monitoring. So even if the patient hemodynamically is doing okay, they all have to have an ICU stay while they are undergoing thrombolysis. So that's why that was a big deal. Strike PE was another one by Penumbra. And this time they were sort of looking at sort of a little bit longer term outcomes, and looking at sort of quality of life afterwards. And so again, sort of low adverse event rate. They had that significant reduction in the RV to LV ratio as previously shown, but then at 90, they followed these patients for 90 days, and they had improvements in all of their sort of quality of life measures and their shortness of breath and sort of return to baseline function from a cardiac standpoint. And then Peerless, another Inari one. I think you guys are sensing a trend here. This one was actually a randomized controlled trial. So looking at mechanical thrombectomy with the Inari, head-to-head versus catheter-directed thrombolysis. So this is sort of our first head-to-head of catheter-directed versus catheter-directed. And their endpoint, however, was this sort of convoluted ratio of looking at different things. So looking at all-cause mortality, any intracranial hemorrhage, any major bleeding, and then what they called clinical deterioration or escalation to bailout which I think just means needing additional procedures, and then whether or not they needed an ICU stay. And again, remember, all catheter-directed thrombolysis patients are going to need an ICU stay. So it was a little bit, I think, skewed from the beginning. But regardless, it met its primary endpoint in that it showed that use of Inari obviously had less ICU use after procedure. And then it also showed lower rates of this clinical deterioration or bailout, but no major difference in mortality or bleeding. And then there's lots of trials that are still ongoing. So PE Tract is a big one here in the United States. It's NIH funded, and so it's sort of device agnostic, which is nice. So randomized controlled trial looking at catheter-directed thrombolysis versus anticoagulation alone. And then the rest of them, HiPythos, Storm PE, and Peerless 2, are all industry-based. They're all randomized controlled trials. HiPythos is ECOS, Storm PE is the Penumbra, and Peerless 2 is Inari. So all of those are ongoing, and we look forward to seeing what they have to show. Catheter-directed thrombolysis can be done, again, it's the placement of infusion catheters into the pulmonary artery, sort of directly into the clot, and then infusing TPA directly into the clot instead of infusing it systemically and allowing it to go everywhere. So in theory, you're using less TPA overall, generally probably about half the amount of TPA than you would if you gave a systemic dose, and B, it should be staying more or less localized into the clot in the pulmonary arteries. By the time it sort of gets around to the circulation, it is not as active as it would be as if you just injected it IV. So those are sort of the premises of why it works better. This picture on the left is sort of a general infusion catheter, multi-side hole infusion catheter, one on the right, one on the left pulmonary artery, and the picture on the right is that ultrasound assisted catheter, so an ECOS catheter. It's got these extra little radiopaque markers on it, and so that's how you can sort of tell the difference. Those catheters have an extra lumen, so the regular infusion catheters really just have sort of one central lumen, and that's where the TPA goes. And then these ultrasound assisted catheters have two lumens. One is where the TPA goes, and then they have this separate lumen for a coolant, which is basically normal saline that's run, I think, at like 5 cc's an hour or something, very, very low rate. But that is to a coolant for the ultrasound aspect of it so that it doesn't overheat. But you have to be careful and make sure that you're running normal saline through the correct hole and through the TPA through the correct lumen, and don't get them switched up. So mechanical thrombectomy, there are lots of devices on the market now. I think the most commonly used ones are the Penumbra, who has recently revamped their line. It used to be the Indigo, and now they've got the Flash, but basically it's, they call them all these CAV-T, which is catheter assisted vacuum thrombectomy, I think. And then the Inari device, which they've come out with a couple of different versions as well, but their FlowTriever is the one that's typically used in the pulmonary arteries. And then AngioVac came out with their own one called AlphaVac, which again is just a large bore sort of suction device. And then there are still some people out there who use just fragmentation. So basically using a pigtail catheter, and you get it into the pulmonary arteries and you just kind of twirl it around and try to macerate the clot as much as you can. Again, with the goal of sort of relieving that big major central clot burden that's causing the backup and sending sort of fragments out, smaller fragments out that won't be quite as burdensome. And then angiojet used to be used. So the POSIS device, rheolytic thrombectomy used to be used, but now has a black box warning because of many procedure-related deaths. So really no one is using angiojet in the pulmonary arteries anymore. So procedure, sort of just kind of step by step of how I approach things. You can go either from the right internal jugular vein or the right common femoral vein. I guess you can go from the left common femoral vein as well, but right tends to be a little bit of a straighter shot. I personally kind of like the jugular vein. Patients are able to sit up after the procedure, which is kind of nice. However, you do end up with a lot of sort of stuff at the neck. And so if you put it at the groin, then that's, less bulk that they have at their neck, but they tend to have to, be more or less flat for the procedure so they don't kink their sheaths. So pros and cons. I typically use either a 6 to 7 French sheath. So if you're doing lysis, 6 French is fine for sort of your regular infusion catheters. If you're going to use the ECOS, you generally need a 7 French sheath because the ECOS catheter itself requires a 6 French. And you always want to go 1 French larger than that so that you can, if needed, draw blood off of your sheath while your catheter's in place, because you don't want patients to be getting stuck peripherally for blood draws and things like that while they're undergoing lysis, because they'll just have an increased risk of bleeding and you'll end up with bruises all over. So it's nice to be able to, for the nurses to have something to draw from. So one French size larger than your catheter is a good general rule of thumb. Obviously, if you're doing thrombectomy, you're going to need much larger sheaths. And each device is going to be a little bit different. If you need a large sheath, you can either do a purse string closure, or you can pre-close the vein with like the per-close device, similar to what we do with large arterial accesses for aortic endografts and things like that. We have shown that it's safe to use these kind of devices, these suture-related closure devices in veins as well, although a purse string suture works just fine too. Typically, to get into the to the right ventricle and to the pulmonary outflow tract, we use either a pigtail or some sort of a shaped catheter with a pigtail on the end, like a Grolman or a pulmonary artery catheter. Those are the shape on them sort of helps you sort of make that turn either from the neck or from the groin without having to use a wire or something else. If you have a tip deflecting wire, you can also use that. And if you don't know what a tip deflecting wire is, it's basically a wire that has a mechanism where you can take it from sort of straight to bent using a device on the back end of the wire. So it's got some stiffness in it that can bend your catheter and help your catheter sort of make those turns. Also, just a glide wire with your pigtail can also be very effective. You just have to make sure that you're not, especially when coming from the neck, that you don't go through the chordae tendineae as you're from the valves as you're coming in from the right atrium to the right ventricle. Just because if you use a larger device, so this is more for thrombectomy. So if you taking a larger device or a sheath and you end up underneath one of those chordae tendineae, you can actually break it. And so you can cause some valvular dysfunction in the future. So if you're just doing thrombolysis, a 5 French catheter under the chordae tendineae is probably not going to cause any damage. And so it's not quite as a concern. I usually measure my right heart pressures on the way in. So when I first get into the right atrium, before I even attempt to get into the pulmonary arteries, I measure my right atrial pressure. If I can sort of get somewhat stable in the right ventricle without causing a lot of ectopy, then I might measure the RV pressure. But some patients are just very sensitive, and having anything in the RV for any period of time, just causes a bunch of ectopy. And so don't want that. So if that's what's happening, then I just move on to the pulmonary arteries and then try to get main pulmonary artery pressures as well as right and left pulmonary artery pressures. So get the main pulmonary artery pressure on your first way in, and then whichever direction the catheter wants to go, it usually wants to go one way or the other on its own. And if you have bilateral PE, then that's fine. You just let it go wherever it wants to go, measure that pressure. And then you can measure the other pressure when you have to get access to the other side. If you want to do pulmonary angiography, then you just need to be cognizant that the patient already has, elevated pressures in their right heart. And so you don't want to overload them even more. So you won't, in a normal patient, you might typically do like a 15 for 30 or even a 20 for 40 because you've got a lot of, vascular bed that you're trying to fill. But patients who have pulmonary hypertension because of this PE, you want to reduce that down. So you can either do like 8 for 15 if you're going to do a power injection. I typically don't. I typically just do a hand injection. And so you have a 10 cc syringe of contrast in it. And so you're just doing a hand injection and you can sort of modulate kind of how much you're giving. We typically have, pretty good CTAs prior to procedure. So we're not really needing this for diagnostic purposes of like trying to figure out where the clot burden is or anything like that. So, it's often just sort of a confirmation of, yes, we're in the right pulmonary artery, or this is, where we think we need to be. And so, I don't worry too much about getting sort of the best images ever and just kind of get confirmation images. And then, once you're in the pulmonary artery, you may have to switch out to a different catheter if you can't get your pigtail to sort of select where you need it to select. So sometimes by the time you get your pigtail to unfurl with your wire out and you pull back, then you might just lose access altogether, and it can be kind of frustrating. So sometimes you might need to switch it out. Regardless, once you're in one side or the other, get a stiff wire out like an Amplatz, and then take your pigtail out and put your infusion catheter in. So typically your infusion links are pretty short because you're really only going, to that sort of central aspect of your pulmonary artery. And so typical infusion links are anywhere between 5 and 10 cms on each side. And then once you do one side, then you kind of start over with your pigtail going through the right heart and try to get to the other side. I typically do 2 separate sheaths. So if I'm doing bilateral infusion catheters, I do what we call, a vampire stick or two axes side by side in the neck. And that's, again, you can use one sort of larger sheath, but then you're more likely to have like dripping around the catheters outside of the sheath because your valve's not going to be able to close as well on that sheath with 2 different catheters coming out. So I like doing 2 different sheaths. And so I get second access and then go back in with my pigtail to get into the pulmonary artery, and then use my wire to direct to the other side, and then kind of do all the steps again. All right, before we move on to cases, are there any questions so far? Okay.
Dr. Amy,
Yeah.
concerning the absolute contraindication, for instance, the intracranial hemorrhage, previous stroke, how do we handle such cases if presented with a acute pulmonary embolism?
Yeah, so then you're, if you can't do lysis, then you're looking at thrombectomy, right? So then that's when you're gonna think about using, if you have an aspiration catheter of some sort, whether it be penumbra or inari or anything else, you can also use a guide catheter and just aspirate it with a syringe if that's all that you have available. That's kind of what you're looking at, is trying to just debulk as much as you can with the resources that you have versus putting them on anticoagulation alone.
Okay, thank you.
Yeah. All right. So first case here, a 73-year-old woman. She has a history of ovarian cancer. She came in with shortness of breath and syncope. On arrival, her blood pressure was 105/70, heart rate was 110, respiratory rate was 20, and she was setting 97% on 15 liters of a non-rebreather mask, which is sort of our equivalent of the highest oxygen level we can give prior to intubating or providing like a BiPAP. Her lactate was elevated at 4. Her troponin was elevated at 0.98, and her BNP was elevated at 490. And I've given you some normal values at the bottom, in case you're not used to looking at these values. But so she's got elevated biomarkers, she's hypotensive, and has vital signs changes. So has hemodynamic changes and elevated biomarkers. And then this is her CT, and so you can see she's got sort of this central saddle clot, or almost a saddle clot going into the left main, into the main pulmonary artery. And then she also has clot in her, all of her lobar arteries bilaterally, with a little bit of clot in sort of the peripheral part of the right main pulmonary artery. So we brought her to the interventional suite. We put in bilateral infusion catheters. And so you can sort of, you can see the two sheaths coming in from the top, and then bilateral catheters. The two radiopic markers are denoting the extent of the side holes for the infusion. And then we brought her back the next day, and we have the unique capability of being able to perform CT in our angio suite. So we had her on our angio table, but we also did a on-table CT. And this is what she looked like after 12, 18 hours of thrombolysis. And so you can see that central clot is completely gone, as is the clot that was in those sort of central aspects of the lobar arteries. And so for the most part, her pulmonary arteries are pretty clean, and we don't see any major central thrombus anymore. And so she did quite well, but this is just a sort of an interesting academic case, and kind of goes to show you what catheter-directed thrombolysis is actually doing, and it is can actually help quite a bit to relieve that clot burden relatively quickly. And then a second case here, 76-year-old woman. She's a Jehovah's Witness. I don't know if you guys have a lot of Jehovah's Witness in Tanzania, but what that means to us is that they do not accept blood products. And so even most of the time, even their own blood products, like if they bank their own blood or something like that, but just for religious reasons, they won't accept blood transfusions or anything like that. She did have a history of a stroke. She came in with shortness of breath as well as a cough. She was only satting 82% on room air when she arrived, improved, slightly to 88 or 90% when we put her on a non-rebreather mask with 10 to 15 liters of oxygen. Troponin was elevated, 1.88. BNP was elevated, 755. Her RV to LV ratio was elevated at 1.4. They did an echo, bedside echo, which showed right ventricular dilation, elevated pulmonary artery pressures, as we would expect based on all of the other clinical parameters. Her PESI score was 96. So she's meeting all of these criteria for at least submassive to massive PE. Here is her CT scan, again showing some central clot, kind of both sides, a little bit more on the right than on the left, and extending out into her lobar and segmental arteries, and as well as into quite a few of her subsegmental arteries. Now, again, given her history of stroke, but as well as her being a Jehovah's Witness, we didn't feel really good about doing thrombolysis, because if she did bleed, we would not be able to give her any blood products. And I apologize for how fast this video is, but if it doesn't give you a stroke, just it's to show you that there's a lot of clot burden in that right side. So we decided to do large bore thrombectomy on her. So this is the Inari sheath in place, and you can just sort of see all those filling defects on the right. And then that picture on the right is the FlowTriever device as we were deploying it. And then so basically it's kind of this basket-like thing. You put it out into the clot, and then you pull it back into this sheath. And then it's also got a suction, large syringe on it that you can also do suction with. So it's got kind of two different things that you can do. This is the amount of clot we were able to pull out. So I just showed you the right, but we also, of course, did the left. And the right, we already knew had a lot more clot in it than the left, just based on that pre-procedure CT. And so you can see how much clot we got out on the right and the little bit of clot we got out on the left. And then this is our post angiography pictures with a main pulmonary artery injection, and all those filling defects are gone. So both the right and the left have good flow, and she did quite well, symptomatically improved, and was able to kind of wean off her oxygen overnight. So just a real quick note on what we call a pulmonary embolus response team. These are fairly common at larger institutions around the United States, particularly in academic institutions, but a lot of private institutions also have developed these. These are a multidisciplinary team. It usually is consisting of IR, critical care / pulmonology. Sometimes cardiology is involved, sometimes cardiac surgery is involved. If IR is not the one that does a lot of the PEs, then maybe vascular surgery is involved. So it sort of depends. But anyone who's sort of, involved in taking care of PE patients gets on the phone when a patient with either a submassive or a massive PE comes in. Again, not so much for these low risk patients, right? Because those are going to get anticoagulation alone. And so we don't typically need to talk about them as a group. But when someone with a higher category PE comes in, everyone gets paged. You get this alert page that gets sent out. I was on call last night. I got a PERT page, and you call back, everybody gets on the phone, and you talk about the patient. So whoever is evaluating the patient, it's usually an ER doctor, is presenting the patient, says, I have this patient here with yada, yada, yada history. And, here's their vital signs, and here's their labs. And, and usually IR, whoever's on, is looking at the images, and then we all kind of discuss together and say, I think that this patient would benefit from, this type of intervention, or, maybe we should try anticoagulation and see how they do, and like monitor them overnight and get them up to walk the next day. And if they, that we call this the walk test, and then sometimes their oxygen will fall massively, when they try to walk. And so then we think, okay, maybe we need to do something a little more invasive. Sometimes we get calls from, hospitals that aren't ours. And so transfer type calls, patients, who are at community hospitals that are a couple of hours away from us, but don't have the resources there to do any of these interventions. And so, then we're kind of talking with, do we need to transfer them? Are they stable enough to transfer? Should they get systemic TPA, wherever they are? Should you just start an anticoagulation and monitor them, or do they need to be transferred right away so that we can, immediately do something for them? So these are all the discussions that happen. And then this, again, kind of a busy slide, but this is our algorithm that we kind of follow. Notice at the top is that same ESC guideline. So it's the exact same graphic. So everyone, we kind of have that as we're looking at it, and we can kind of follow along and say, okay, where do they fall? What category are they in? And then at the top right is the contraindications to lysis. So again, that can always be top of mind. So you can don't have to try to, pull these from memory. You've got them right here. And then you just kind of follow down, the algorithm as we go. So do they have contraindications to lysis? Yes or no? Do they need ECMO? Yes or no? Where do they fall on the ESC guidelines? Are they low risk, intermediate risk? And kind of work your way down. And so these are all again, just kind of to help us figure out what we think is going to be best for the patient, given the data that we have as far as sort of outcomes and things like that. And so this is subject to change, as new technologies come out, new devices come out, new data comes out from some of these trials that are happening. We might find out that, we're doing lysis on patients, and they're, ultimately their outcomes are the same as if they got systemic anticoagulation. And so we're putting them through a procedure that they don't need. Or alternatively, we might find out that, doing lysis on patients, even the ones that will probably do fine with anticoagulation, you know, down the line, they have better outcomes than if they just got anticoagulation alone, and we should actually be doing more catheter-directed thrombolysis on patients. We don't know. So, you know, as we learn more and get more data, then all of this is subject to change, but this is just our particular institution's kind of algorithm that we use. All right. So I have, I think, 3 practice questions. But before I kind of move on to those, any other questions?
Yes, please. Thank you so much for the presentations this far. I wanted to find out whether you do double stick access to for every patient who has bilateral PE, even when you're doing mechanical thrombectomy, or is it just one sheath in that case, and you do double for only catheter-directed thrombolysis?
Yes, good question. Yes, for thrombectomy, I'm just using one sheath. It's one very large sheath, usually usually somewhere 16, 18 French for those larger devices. So yeah, it's just one sheath for those because you're going in one side at a time, but you're using the same device. So
yeah, thank you.
Right
That's helpful. I was just wondering how those two are able to fit in.
Yeah, yeah.
Okay.
Yeah, so you just do one side at a time when you're doing thrombectomy, so you only need one access.
All right, thank you.
Yeah. All right. We'll do some practice questions, and then hopefully there'll be a couple of minutes left if anyone else has questions at the end. All right. So 26-year-old man comes in with shortness of breath. CTA shows he has a PE in both with both central and peripheral clot burden. His blood pressure is 132/65. Heart rate is 80. Respiratory rate is 12. He's standing 98% on room air. His serum labs are normal. So what PE category is this according to the American Heart Association? Is this low risk, submassive, or massive?
Low risk.
I love that. Yes, low risk. Good job. All right. Now, which of the following is a contraindication to thrombolysis? Someone who had knee surgery 3 months ago, someone who takes a daily aspirin, someone who has metastatic disease to the brain, or a woman who is currently menstruating.
C, metastatic disease to the brain.
Look at you guys go. Great job. All right, last question, I think. 68-year-old woman comes in with shortness of breath and chest pain. She has the CTA that is shown to the right. So which of the following is an indication for her to undergo catheter-directed thrombolysis? Is it an RV to LV ratio of 0.8? Elevated cardiac biomarkers such as troponin or BNP? If she has subsegmental pulmonary emboli? Or if she has a systolic blood pressure of 120?
B, elevated cardiac biomarkers.
Wow, you guys are excellent. Perfect. And I'll have you know that this is, I actually write questions for the American Board of Radiology for the ongoing like maintenance of certification. And this is actually one of the questions that I wrote. So you guys are all over it, answering real questions. All right. So that's all I have today. Happy to answer any other questions that you guys might have.